Okay, kindly go ahead if you can see the screen.
Okay.
It's 211, right?
Yes, 211 to 215.
Okay. Can you see the screen, please?
Yes, I can.
So kindly go ahead.
Okay. Good evening, our chiefs. Good evening, senior colleagues. Good evening, colleagues. I'll be taking 211 to 215. 211. Which of the following, which statements regarding the use of fibrinolytic therapy in acute myocardial infarction is true? So fibrinolytic therapy reduces the mortality of ST segment elevation by 70% at 35 days after the event. Compared with patients with anterior ST elevation, those who present with left bundle branch block have a similar risk reduction with fibrinolytic therapy. Compared with patients with anterior ST segment elevation, patients with inferior ST segment elevation demonstrates a greater risk reduction with fibrinolytic therapy. Clinical trial data demonstrates no mortality benefits of fibrinolysis administered more than 6 hours after the onset of symptoms. Patients older than 75 years experience a greater relative reduction in mortality than patients younger than 55. So let me just give us a brief overview of fibrinolytic therapy. So it's a therapy that is given in areas where there is no access to percutaneous intervention, and it involves the use of agents which will help to break down the thrombus in the setting of an acute myocardial infarction. So we have different agents that are used. You can use streptokinase, alteplase, tenecteplase, relteplase. Usually fibrinolytic therapy is best. The best studies have found that the best benefit of fibrinolysis is gotten within 12 hours after the onset of the myocardial infarction. There is usually no benefits if it is given after this particular period. And for the indications, or the contraindications to fibrinolytic therapy, we have the absolute contraindications and then the relative contraindications. The absolute contraindications are previous hemorrhagic stroke at any time or ischemic stroke within 3 months prior to the myocardial infarction. If there is a presence of known intracranial neoplasm and there's structural cerebral vascular lesions or closed head injury within 3 months, an active bleed or bleeding diastasis, excluding menstruation, if there is a suspected aortic dissection, intracranial or intraspinal surgery in the last 2 months, severe uncontrolled hypertension unresponsive to medical therapy, or in the place of in places where you want to use streptokinase, which is commonly used here in Nigeria, is if there's a prior exposure to streptokinase use in the last 6 months, that's an absolute contraindication to use of streptokinase again in that patient. So the relative contraindication to fibrinolytic agents in the management of myocardial infarction, the relatives are severe uncontrolled hypertension at presentation. That's if the blood pressure is more than 180, 110. History of ischemic stroke more than 3 months, or dementia, or known cerebral pathologic conditions not covered in the absolute contraindications. The use of oral anticoagulant therapy, traumatic or prolonged CPR or major surgery less than 3 weeks prior to myocardial infarction, a non-compressible vascular puncture. That means the risk of bleeding in such patients is very high. So it's a relative contraindication, or recent internal bleeding within 2 to 3 weeks, pregnancy, and active peptic ulcer disease. These are some of the relative contraindications to fibrinolytic agents. And then fibrinolytic therapy has been found to it reduces the mortality in those that have acute ST elevation by 15 to 20% at 35 days follow-up period. And it's been found that the effect is seen relatively equally in those that have anterior that's ST elevation in the anterior segments, and those that also have left bundle branch block, but it's of lower effect in those that have inferior myocardial infarction. Let me see. So those that are older than 75 is one of the fact that fibrinolysis is also not advised to be given in people that are more than 75 because their risk of bleeding is relatively high, and it tends to neutralize the benefits that you might actually get if you give fibrinolytic agents in such age group. So now let's, I think with that, we can go back to the question. So fibrinolytic option A. So we are looking for the true, I think it's the true answer, I guess. I think it's the true. So fibrinolytic therapy reduces the mortality of ST segment elevation myocardial infarction by 70% at 35 days after the event. It's not up to that. It's 15 to 20% at 35 days. So that option is false. So compared with patients with anterior ST segment elevation, those who present with left bundle branch block have similar risk reduction with fibrinolytic therapy. That is true. But we should know that it is lower in those that have inferior ST segment elevation. So let's look at option C. Compared with patients with anterior STEMI, patients with inferior STEMI elevation demonstrate a greater risk reduction. So it's opposite. Those that have anterior STEMI have a greater risk reduction compared to the inferior STEMI. So clinical trials demonstrate no mortality benefits of fibrinolysis administered more than 6 hours. You can give for as long as 12 hours. So that option is false. Patients older than 75 years experience a greater relative reduction in mortality than patients younger than 55 years. For that option, in those that are above 75, the benefits is there, but the risk of bleeding actually outweighs that benefit. So that makes that option E to be false. So for this number 211, the answer is B. Any comments or contribution?
Thank you very much. So just for re-emphasis, the definition for a successful thrombolysis in STEMI is a reduction in your ST segment greater than or equal to 50% within 60 to 90 minutes. Some references say 30 to 60, but 60 to 90 minutes is also acceptable. So let's remember that when you thrombolize, it doesn't mean that it will be successful. So when you thrombolize a patient, especially for those who do not have successful thrombolysis as defined by the ST segment, they need to go for a rescue PCR. Thank you very much.
Yes, thank you. In addition to that, the resolution of the chest pain, the presence of arrhythmias, idioventricular rhythm on your ECG monitoring, those are some of the things that you expect to see if you have a successful thrombolysis for MCQ purposes and even for real life practice. So we should look out for all those things in those patients. Thank you very much, Dr. Wijan. So I'll move to number 212. Which statement regarding acute coronary syndrome is false? So which statement regarding acute coronary syndrome is false? A, occlusive coronary thrombosis is typically responsible for ST segment elevation. B, non-occlusive coronary thrombosis typically presents with ST depression and or T-wave inversion. C, Q-wave develops in approximately 75% of patients with ST segment elevation myocardial infarction who do not undergo acute reperfusion intervention. D, the presence of a pathologic Q-wave reliably indicates the transmural involvement of myocardial infarction. So for this question, we know that if you have for myocardial infarction, a complete occlusion of the vessels tend to give an ST segment elevation on our ECG. But if you have a partial or incomplete occlusion or thrombus formation, it tends to give the T-wave inversions and then the ST depressions. So when you have all this, they give the patient the typical angina, whether stable or unstable. Then if you have coexisting elevated troponins, then you say the person has a non-ST elevation myocardial infarction. In the past, we know that most patients thought to be due to complete occlusion to all the layers of the myocardium. But further studies have shown that the presence of a hello, can you hear me?
Right.
So the presence of a Q wave does not necessarily mean that is a transmural infarct. That is usually commonly seen in those that have very large areas of infarcts, are those that have a Q wave formation. So if we look at this question now, 212, occlusive coronary thrombosis is typically, you can see the way they made the question. So they didn't say always, it's typically responsible for ST segment elevation. That is true. Non-occlusive thrombosis typically results in ST segment depression and or T-wave inversion. That is true. Q-wave develops in about 75% of patients with ST segment elevation myocardial infarction who do not undergo acute perfusion interventions. That is also true. And then the presence of the pathologic Q-wave reliably indicates transmural involvement. It's not necessary. If it's a large impact that is not transmural, you can have conversion of the ST elevation to Q-wave. So the false option in 212 is option D. Any comments? Two 13. Which statement regarding PCI, coronary intervention, performed by experienced operators in acute ST elevation myocardial infarction is false? So which of the following is false? PCI results in a higher coronary artery patency rate than fibrinolysis. PCI results in lower mortality than fibrinolysis. Radial artery access and femoral artery access in primary PCI results in similar rates of mortality and bleeding complications. PCI results in lower stroke rates compared to fibrinolysis. So we know that in the past, fibrinolysis was initially done before the advent of percutaneous interventions, where stents, initially bare metal stents, were used, and then with further studies, drug-eluting stents have been reintroduced, and this has drastically reduced the mortality and the morbidity associated with myocardial infarction. Studies comparing fibrinolysis and stents and stent use have found that the risk of bleeding associated with fibrinolysis, which commonly the bleeding that occurs with fibrinolysis is intracerebral hemorrhage, can even be as high as 0.5 to 0.7% in those that are undergoing fibrinolytic therapy, that is quite significant compared to those that have that undergo percutaneous intervention. So the risk of bleeding because of the agents, especially if you are using the older agents, that's especially to kinase, the risk of bleeding is usually higher. And then the outcome, the studies have also found that by comparing the stents and they do the TIMI flow for such patients, it's usually even better. The outcome in those that undergo PCI is better than those that undergo fibrinolytic therapy. The risk of stroke is lower in PCI therapy. And then the access for doing a PCI, initially methods such as using a femoral access was what was routinely used for PCI intervention. But there were complications that occurred with that, the bleeding risk, dislodgement of thrombi, and other complications. And then studies have found that the radial access had less chances of having these complications. The risks were actually lower. So in most centers now, radial access is usually preferred compared to femoral access when a PCI is done. So we'll go back to the question. So PCI results in higher coronary artery patency rates than fibrinolysis. That is true. PCI results in lower mortality than fibrinolysis. That is also true. Radial artery access and femoral artery access in primary PCI, the bleeding is more with femoral. Then PCI results in lower stroke rates than fibrinolysis. That is also true. So the answer in this question is option C. Any comments or contribution? So in the absence of any, I'll move to 214. So which of the following statements about left ventricular LV aneurysm after myocardial infarction is not correct? So which of the following about LV ventricular aneurysm after MI is not correct? Aneurysms typically range from 1 to 8 centimeters in diameter. Inferior posterior aneurysms are more common than apical aneurysms. The presence of an aneurysm increases the mortality rate compared with patients with similar ejection fractions without an aneurysm. Persistent ST segment elevation on ECG does not necessarily indicate an aneurysm formation. True LV aneurysm rarely ruptures. So one of the structural or mechanical complication of acute myocardial infarction is actually an aneurysm formation, and it usually occurs when there is blood flow. If there is reduction in blood flow, necrosis, and destruction of the wall, there'll be an infarction, and by the time this area of necrosis, it will lead to the area being weakened. The wall is actually very is weakened, and then it can become an aneurysm. So usually collaterals can actually help to prevent the presence of a multivessel extensive collaterals, or when it's not occluded, will make the chances of having an aneurysm less likely, because the blood flow to an area that has a myocardial infarction is not completely cut off. So it's the aneurysms usually, you know, that the blood flow to the apex, it's as the blood flow terminates most of the time around the apex. So the blood flow and the presence of collaterals may not be as it should be compared to other sides of the heart. So aneurysms tend to form most likely at the apex, and then the anterior wall than in the inferior posterior wall. And usually their diameter is said to be from about 1 centimeter to 8 centimeters. The true aneurysms, because, you know, the aneurysm, that means all the wall of the myocardium, all the 3 layers of the myocardium actually forms the wall of the aneurysm. That's a true LV aneurysm. They rarely rupture, because there is still like this, the presence of all this still gives it like the integrity and less likely to rupture. Unlike insidious aneurysms, because, you know, there is like an intramural extension, and then the walls are not, the integrity is not so much, because not all the layers of the wall are actually present. So the pseudoaneurysms tend to rupture, and we know that ventricular rupture, especially setting of myocardial infarction, can actually be very disastrous. The mortality rate can be as high as 80% if no surgical intervention is actually given to such patients. So the mortality rate, even in the presence of an ordinary aneurysm, even if it doesn't rupture, the mortality rate in them is usually higher than those who don't have coexisting aneurysm. And it usually occurs due to the fact that the ischemic area, the aneurysmal pouch, increases the chances of having arrhythmias. And the diagnosis of aneurysms is usually suspected if you have persistent ST segments elevation. However, one of the other things can cause persistent ST segment elevation in the setting of the myocardial infarction if there's still an ongoing MI, and then if there is pericarditis, if there's an aneurysm. Those are the things that can give persistent ST segment elevation. Especially if you also have a very large infarct. So aneurysm is not the only cause of the persistent ST segment elevation post-MI. So if we go back to the question, let me start from option E. That's what I can see clearly now. So option E says that true aneurysm rarely ruptures. That's true. So, but it's a pseudo aneurysm, it has higher propensity to actually rupture. So persistence of ST segment elevation on the ECG does not necessarily indicate an aneurysmal formation. So that is also true. There might be other things, pericarditis, persistent persistent MI, when you have not achieved the perfusion, can also cause persistent ST elevation. So that is true. The presence of an aneurysm increases the mortality rate compared to those with similar ejection fractions without an aneurysm. That is also true. You know that aneurysm also increases the chance of having clot formation in the aneurysmal space. So option B. Please, can you let me take it to option B? Thank you. So inferior posterior aneurysms are more common than the apical aneurysms. That's false. The apex is because there are less collaterals there. So the apex is more likely, is the area that is most likely. So that's actually the average range for aneurysms post-MI. So any contributions, please? So in the absence of any, I'll go to number 215. Thank you. So 215, the rhythm shown in figure 2.3. So can you just please scroll up? The rhythm strip is up. It developed in a 72-year-old man on the second day of hospitalization for an acute ST segment elevation myocardial infarction. Which statement is not correct? So let's just look at the rhythm. So this rhythm is atrial fibrillation with rapid ventricular response is what we can see on this rhythm strip in this patient post-MI. So the presence of this rhythm in ST segment elevation is associated with increased mortality. So that is true because the filling, the ability of the artery to pump enough blood, the filling is actually affected, cardiac output is affected because of the atrial fibrillation that is there. So there's usually associated increased mortality if you have the presence of a atrial fibrillation post-MI. So option A is true. This rhythm tends to be persistent rather than transient in the setting of acute ST segment elevation. It's been found that the new onset atrial fibrillation post-myocardial infarction tends to be transient. It resolves usually on its own. So it's like part of the arrhythmias, arrhythmias that occur due to the ischemia that is ongoing in the setting of an acute myocardial infarction. So the atrial fibrillation usually is transient in the setting of an acute MI. It's been said to actually it can resolve on its own spontaneously. However, when it actually occurs, it can be catastrophic and is associated with higher mortality due to reduced perfusion and cardiovascular hemodynamic compromise that can occur due to the rapid ventricular response in this setting. So this rhythm may result from left ventricular failure, pericarditis, and a left atrial ischemia in the setting of STEMI. So like I mentioned, because of the ischemic process that is ongoing, the inflammatory process that can also occur due to pericarditis, even the coexisting heart failure that can occur in the setting of acute MI. All these are they're like prostrates, they're like risk factors to having atrial fibrillation The rhythm can actually occur from any of all these, which are common features that are seen in myocardial infarction. So if I start with hemodynamic compromise, so we should note that first part of the question, if there is hemodynamic compromise, then we can treat with immediate electrical conversion or cardioversion. So if if the patient is stable and there is no hemodynamic compromise, we can use beta. The BP is fine post-MI. One of the arrhythmias that a beta blocker can help to prevent from happening that can actually worsen the outcome in such patients. So, but if there is hemodynamic compromise, is advisable to cardiovert and halt the arrhythmia immediately. So for question 215, so the option that is not correct is that this rhythm tends to be persistent rather than transient in the setting of acute STEMI. Atrial fibrillation is usually transient, it's not persistent. So the answer is B for 215. Any comments or contribution? That's the end of my.
Yeah, thank you very much. We're grateful for stepping in. Okay, I think there's a question or contribution. Kindly go ahead. Hello?
Just a clarification.
Your network is quite unstable, so let's see if you can put it in the chat box. Probably she can read it and we can answer that. Because we could hardly hear you.
201, 211. My network went off. How did you arrive at option B for 211?
For 211, okay.
Can you hear me? Can you hear me now?
Yes, I can hear you.
How did you arrive at?
How you deduce the option B for 211?
Yes.
This is ready for.
Hello, Dr. Mokere.
Yes, I'm with you. I'm trying to read the question. Okay. So that is a study. It's a study-based answer. It's a study-based answer. Is not well, I will not say it's not theoretical, it's a study-based answer. And all others are clear-cut, they are wrong. By the time you look through all others, even in clinical practice. So that's actually how I got about that's how I got the answer.
Okay. Thank you.
Do you understand? Yes. This is a study.
Okay, thank you.
You're welcome.
Okay, so Dr. Okedara is on. Dr. Okedara. Hello, Dr. Okedara.
Hello, Chief.
Yeah.
Good evening, everybody.
Are we ready to go?
Yes.
All right. So I'll end my slide share, then you can upload. Then we take it from there.
Okay. Can you please share? I can share my slides. Okay. Good evening, chiefs, colleagues on the call. So I'll be taking gross anatomy of the heart valves, conduction system, and coronary circulation this evening. By way of introduction, the heart can be said to have a fibrous skeleton on which the muscles of the atria and the ventricles are anchored. The skeleton consists of fibrous connective tissue that forms the valvular annuli and electrically isolates the atria and ventricular muscles, except in one small area. The fibrous skeleton consists of the mitral, tricuspid, and aortic annuli in a closed triangular arrangement. The separate pulmonic annuli is anterior and leftward of the aortic annulus. The small fibrous junction between the mitral, tricuspid, and aortic cannuli is called the right fibrous trigon, also known as the central fibrous body. And the small fibrous junction between the mitral and aortic cannuli on the left, behind the left atrial appendage, is called the left fibrous trigon. The bundle of E's penetrates the right fibrous trigon in coursing towards the left side of the interventricular septum. So this is an image that is showing that. I'll just quickly take us through. So this, where this asterisk is the central fibrous body. That is where you can see the septal leaflet of the tricuspid valve, the aorta, and then the mitral valve, the mural leaflet of the mitral valve. You can see that's where the right trigon is. Then the left trigon is in between the anterior leaflet of the mitral valve and the aorta here. So this is the right coronary artery taking origin from the right coronary sinus, and this is the left coronary artery taking origin from the left coronary sinus, and this is the pulmonary valve. I said
It
that
started working elsewhere when. Oh,
pardon? So I said earlier that the pulmonary valve is leftward and anterior relative to the aorta, to the aortic valve. You can see where it is. Okay, so this fibroskeleton has all these valves within them, the annuli of all these valves within them. So the heart has two groups of valves, which includes atrioventricular valves and semilunar valves. So the atrioventricular valves consist of mitral valve and tricuspid valve, while the semilunar valves are the aortic valve and pulmonary valve. So I'll start with tricuspid valve. The tricuspid valve leaflets hang from the atrioventricular annulus into the cavity of the right ventricle. So the leaflet attachment is continuous around the right atrioventricular ring. However, the hinge line is where the chordae tendineae attaches the papillary muscles to the leaflets. So that hinge line varies from segment to segment. So it's not a straight line. So medially, the hinge of the tricuspid valve crosses the middle of the membranous portion of the interventricular septum. So the fibromembranous tissue comprising these leaflets can be divided roughly into 3 leaflets, the largest being the anterior leaflets, talking about the leaflets of the tricuspid valve. So the largest is the anterior leaflet and the smallest is the posterior, with the septal leaflets being intermediate in size. The notched or undulating leaflet edges or free margins are attached to papillary muscles by fibrous cords called chordae tendineae that branch once or twice before their leaflet attachments at variable distances from the edge. That's still talking about the variability in the hinge. So the chordae are thinnest at the leaflet edge and thicker in attaching on the ventricular aspect. So the leaflet has a ventricular aspect and an upper aspect facing the atrium. Each leaflet receives chordae from more than one papillary muscle. So whether it's the anterior, it's the septal, or it's the posterior, they can receive chordae tendineae from any of the papillary muscles. The smooth atrial surface of each leaflet is the surface that coapts or fits together during systole. So the anterior leaflet is situated subjacent to the sternocostal area and is tethered by chordae primarily from the anterior papillary muscle, with a limited contribution of chordae from a small papillary muscle near the outlet septum known as muscle of Lancisi or papillary muscle of the conus. I'll still show this in images. The septal leaflet has chordae that insert directly into the interventricular septum. That's the septal leaflet, and I think it derives its name from there. It has chordae that inserts directly into the interventricular septum. So it's not attaching to a papillary muscle that now attaches to trabeculae. In this situation, it's attaching directly to the interventricular septum. The posterior leaflet is positioned inferiorly and is tethered by chordae from a variable number of very small papillary muscles along the right ventricular inlet inferiorly. Of clinical significance is the attachment of the tricuspid valve at the commissure between the anterior and septal leaflets across the membranous septum. So due to this attachment, it's possible to have a perimembranous septal defect at that point with left ventricle to right atrial shunt. So this is an image that is showing the leaflets of the tricuspid valve. So this is the anterior leaflet of the tricuspid valve. You can see this is the anterior papillary muscle that is anchoring it through the cordy tendinae to the trabeculum. And this is the septal leaflet of the tricuspid valve. And this is septomarginal trabeculum. So there are some special trabeculae, including septomarginal trabeculum, moderator band. I'll still talk about them later. So in other things like landmarks, upper hair, you see the pectinis muscle, that's the rough part of the right atrium. This is the sinus venereum, the smooth part, fossa ovalis. This is the posterior descending coronary artery. So, okay, so this image we can see this is where the asterisk is the membranous portion of the interventricular septum, and this is the muscular portion. And so this is the point where you have this is the point where we can have ventricular septal defects with left to right shunts at this point. And it said that the commissure between the anterior leaflet of the tricuspid valve and the septal leaflet of the tricuspid valve crosses this point where we have the membranous part of the IVS. So, okay, so this image here we have what is called the crista supraventricularis. It separates the inflow from the outflow of the RV. So towards this place we have the RVOT, and here we have the inflow. So this is still the anterior leaflets. This is the septal leaflets, and this is papillary muscle of the conus, muscle of Lancet that I earlier talked about, that contributes alongside it contributes to the attachment of the anterior leaflet of the tricuspid valve to papillary muscle. So the anterior leaflet is attacked by the anterior papillary muscle, and this muscle of Lancet to the trabeculae of the RV. So I decided to chip in a slide on RV because there are some things that I think it will make us understand it better. So RB is triangular. The right ventricle is triangular with one side, the right atrioventricular orifice. That's one side. The second side is the diaphragmatic aspect, the side that is lying on the diaphragm. And the third side is the one adjacent to the interventricular septum. So the superior extent of the triangle leads to the RVOT. So on echo, you see the robust IVS bulges into the cavity of the right ventricle. So it makes it look like a crescent wrapping around the LV because the pressure on the left side is greater than the pressure on the right side. So separating inflow and outflow is what I said earlier that I depicted in the image. Crista supraventricularis is a structure that forms an arch with one arm on the IVS and the second arm on the free wall of the right ventricle. I'll just quickly show it again. This is it. This is it. So there's an arm towards the IVS and there's an arm towards the free wall of the RV. So let me go back. Okay. So anatomically distinctive of the RV is, see, this crista supraventricularis is derived from the inferior margin of embryologic conus arteriosus. Also characteristic of the RV is trabeculated septal surface. So it has more trabeculae than the LV at the septal surface. The side of the LV is smooth. One of the more prominent trabeculums, the septomarginal trabeculum, courses in the long axis along the anterior septum at its typical end. Then we have what is called the short muscular trabecular ridge called moderator band. That courses between the distal septum and the free right ventricular wall. Visible by echo, the moderator band carries the right bundle branches of the conduction system. Okay, I've mentioned this earlier, so that's it. So I'll go to mitral valve. The mitral valve is so-called, it sounds like mitre, That's it looks like the cap of a bishop. And the leaflet tissue, so it's hanging from the annulus. So the leaflet tissue includes the anterior or aortic leaflet, because it's bordering on the aorta, and the posterior leaflet, or what is called the moral leaflet. The leaflets are anchored to the LV by chordae tendineae that originate from papillary muscles. In addition, the posterior leaflet has some chordae that come directly from the left ventricular wall. So due to the junction between the aortic and mitral annuli, the left fibrous trigon, so that's the part between the aorta and the mitral, and like I said in the introduction, the anterior leaflet of the mitral valve it has a contact with the non-coronary and left coronary portion of the aortic annulus. Thus, there's a fibrous continuity between the mitral and aortic valves, unlike on the right side where the RVOT, where the tricuspid and pulmonary valves, they are separated by the crista supraventricularis. Like I said, that the inflow and outflow are separated by crista supraventricularis on the right. So the mitral leaflet are somewhat scalloped. The commissures, fan-like arrangement of chordae can be identified on the ventricular aspects. The two major commissures separating the anterior and posterior leaflets are the anterolateral and posteromedial commissures. The posterior leaflet is seen to have two other minor commissures, so it's divided into three. We have the anterolateral, medial, and posteromedial scallops. And the clinical significance is that each of those scallops can prolapse back into the left atrium during systole, forming a distinct angiographic and echocardiographic picture. So the chordae originating from the papillary muscles attached to the free margins of the leaflets and also onto the ventricular surface of the leaflets beyond the free edge. So the architecture subdivides the septal leaflets. So I'll just mention here that the anterior leaflet is taller and extends like 1/3 of the annulus, 1/3 of the whole annulus. It covers that, while the posterior leaflet is about 2/3. It extends over about 2/3 part of the annulus and is more shallow compared to the anterior leaflet. In the anterior leaflet, the smooth portion becomes the intervalvular membrane that attaches to the non-coronary and left coronary portion of the aortic annulus. The posterior leaflet hangs from that portion of the mitral annulus that is adjacent to the position of the coronary sinus. So closure of mitral valve during systole is accomplished by coapting of the atrial surfaces of the two leaflets, and it's important that there should be overlap for proper seal of the valve. Chordae tendineae keep the mitral leaflet from prolapsing into the LA. So some clinical correlates, you can have elongated chordae tendineae that would make it so lax that it's prolapsing back into the left atrium. The chordae originate from anterolateral and posteromedial papillary muscles and distribute to both leaflets. Just like I said in the right side, so that it can come from 2 or 3 going to or papillary muscles going to a particular leaflet. In contrast to the tricuspid valve, there are no mitral valve chordae that attach to the ventricular septum in the normal heart. So the anterolateral papillary muscle blood supply is from the left anterior descending and the diagonal or marginal branch of the left circumflex artery. So it has a dual blood supply. The left circumflex or right coronary artery. The left circumflex or right coronary artery, depending on dominance, provides the blood supply to the posteromedial papillary muscle. Because of its single system of blood supply, this papillary muscle is particularly prone to injury from myocardial infarction. So when there is myocardial infarction, the anterolateral papillary muscle has an option of dual supply, while the posterior has just a single blood supply, making it more prone. The mitral valve apparatus includes 3 groups of chordae. First order chordae arise as fibroelastic cords from the tips of the papillary muscle and insert into the free margin of the valve. This chordae can divide 2 or 3 times before their leaflet attachment. The second order chordae, they are at or near the tips of the papillary muscles, and they arise as strong tendinous cords and attach to the ventricular surface or rough area of the anterior leaflet. So the first order attached to free margin of the valve, while the second order attached to the ventricular surface of the anterior leaflet. The third order chordae originate from left ventricular wall near the atrioventricular ring and attach to ventricular surface of the posterior leaflet only. So this is an image. So you can imagine it that the LV has been cut into two and is being reflected sideways. And up here, where the asterisk is the orifice of the left atrial appendage. Then we have, this is the orifice of left atrial appendage. Sorry about that. This is the left aspect of interatrial septum. So we have the posterior leaflet of the mitral valve is being cut into two, so you can see it on either side. But if you close it, you will know that the posterior is lying, on this side. If you close it and try to imagine it, and the anterior leaflet is here. So, like I said, the anterior leaflet of the mitral valve subtends about 1/3 of the whole annulus, and while posterior leaflet of the mitral valve is 2/3 and more shallower compared to the anterior leaflet, which is taller or wider. So this is the posterior-medial papillary muscle, and this is the anterolateral papillary muscle. So we can see it depicted there. Okay, so this is another one that is showing that fibrous continuity between the anterior leaflet of the mitral valve and here, where it puts on the left coronary cusp and the non-coronary cusp of the aortic valve. So this again is the posterior-medial papillary muscle, and this is posterior and anterolateral papillary muscle. So I'll go on to the aortic valve. The aortic valve guards the outlet from the left ventricle. The valve is semilunar with 3 leaflets suspended from the aortic annulus. The leaflets are named for their positions in situ relative to the body axis. So we have a right coronary leaflet or anterior, left coronary leaflet, and non-coronary leaflet. So during diastole, the aortic walls in the root of the aorta expand well beyond the limits of the aortic annulus, increasing volumes of the 3 sinuses of Valsalva and visible angiographically. So the coronary arteries usually arise from the aortic wall that surrounds these sinuses. And the anatomic relationship of the sinuses of Valsalva as follows. So the right coronary sinus bulges into the posterior aspect of the right ventricular outflow tract. Left coronary sinus abuts the outlet septum anteriorly and faces the transverse sinus posteriorly. The non-coronary sinus is adjacent to the medial wall of the right atrium. The clinical correlate, the reason why we're talking about these landmarks is that injury or aneurysmal formation and rupture in each of these sinuses can result in fistulous communication to the adjacent structures to them, or even into the pericardial space. So in diastole, the 3 aortic leaflets close by a position of their ventricular surfaces. So they have along their edges, that is the leaflets, near the commissures, some holes or fenestrations. That is where the commissures are where the leaflets are adjacent to each other. So they can have holes or fenestrations normally. However, they don't usually cause regurgitation because it's usually above the line of closure. That is when there is coarctation of the leaflets. Those places where you have fenestrations or holes naturally, physiologically, they don't cause regurgitation. Nonetheless, these fenestrations as well as incomplete aortic leaflet coarctation have been considered as the cause for some small aortic regurgitation jets in 5% of normal hearts by Doppler echo. In systole, the opening of the aortic valve forms a rounded triangular orifice with flexion at the wall attachments of the leaflets. If this flexion area becomes calcified, as is seen in advanced stage, various degrees of aortic valve stenosis occur. Okay, so this is an image where the heart has been the aortic, the LVOT and the aortic valve has been cut open. So we can see that this is half of the left coronary leaflet, half here, half there. So if you try to close it, they will oppose, and you know that your left lies to the left, and the right, this is right coronary leaflets, and this is the non-coronary. And this LCA, the left coronary artery ostium. This is where the left coronary will come out. And then this is the sinus of the right coronary artery. So just named after the sinus from which they arise. Okay, so this is an image that is showing the semilunar valves. We have this is the pulmonary valve, and this is the aortic valve. You can see non-coronary, left coronary, right coronary, and this is the right coronary artery orifice. This is the left coronary artery coming from the sinus near the left coronary leaflet. So this is the pulmonary valve. This P stands for posterior leaflet of pulmonary valve, right anterior, left anterior leaflets of the pulmonary valve. So this asterisk is pointing at the fused medial walls of the left. So this is the left atrium and the right atrium. The right atrium is here, and you can see a little bit of the septal leaflet of the tricuspid valve here. So pulmonary valve is situated superior most in the right ventricular triangle, and separating the right ventricle from the main pulmonary artery is the pulmonic valve that faces posteriorly and superiorly. This semilunar valve has 3 leaflets, right and left anterior leaflets, and a single posterior leaflet, named according to their orientation to the main axis of the body when the heart is in situ. So like I just depicted. So the valve leaflets are thin and translucent. It has some fibrous thickening at the free margin with the nodulus aurantius. And radiating from that nodule, you have some fibrous thickenings called lunulae of similar configuration to the aortic leaflets, but they are thinner due to lower forces sustained by pulmonic valve, as the pressure on the right side is less compared to that on the left side. In systole, the leaflet flex at their wall attachment to form a rounded triangular orifice about 3 centimeters squared in diameter. In diastole, the leaflets close by coapting along their ventricular surface. So I'll go on to conduction system now. Although the work of the heart is dependent on myocardial contractility, what we can see, the heart is contracting, relaxing, but the mechanism that initiates and provides order to the phasic contraction and relaxation is dependent on the other 2 fundamental properties of the cardiac muscle. That's automaticity and conductivity. So the conduction system, including nodes, bundle branches, and Purkinje fibers, consists of modified myocardial cells that are positioned to either facilitate or slow impulse conduction. Both the synovial node and AV node are comprised of specialized myocardial cells with highly developed automaticity, and the myocardial cells of the His bundle branches, and Purkinje fibers have specialized property of rapid conductivity. None of the collections of the specialized muscle in the heart is discernible grossly. Most of them were discovered from tedious dissection and microscopy, that is histology. The major portion of the adult synovial node, a 3 by 10 millimeter body of pacemaker nodal cells that is discrete and sausage shaped, normally is situated in subepicardial tissues superolaterally near the junction between the superior vena cava and the right atrial appendage in the sulcus terminalis. The SA node is derived from the right horn of embryonic sinus venosus. If you remember, we've already done embryology, the sinus venosus. The SA node receives its blood supply from sinoatrial nodal artery. It initiates the depolarization that causes the atrial muscle to contract. After impulse spreads through the atrium, it's I forgot to put this. There are some interatrial tracts. Bachman tract is one of them. I can't remember I forgot to input that. So when it reaches the atrioventricular node, after spreading through the atrium, through those tracts, it gets to the AV node. So now there are landmarks for the AV node. The landmarks for AV node form what we call the Cox triangle, bounded by the tendon of Tudaro superiorly. This tendon of Tudaro, I think, is the remnant of the eustachian tube. The annulus, so those are the things. So we have tendon of Tudaro superiorly, annulus of septal leaflet of the tricuspid valve apically. I'll still show the diagram. And an imaginary line in the long axis through the coronary sinus ostium inferiorly. The AV node is comprised of a small bean-shaped mass of specialized myocardial cells that are both the right fibrous trigon between the right and left atria. So this is it. So this is the landmark for the AV node. And this is the Cox triangle. So we have this ER, the Eustachian ridge, and where the arrows are is the tendon of Todaro. That's the remnant of the Eustachian tube. And here is the coronary sinus. There's this line crossing the coronary sinus. And so here is where the landmark for the AV node is, at the apex of this Cox triangle. So other landmarks are as depicted in the image. This is the septal leaflet of the tricuspid valve. Is bordering on this line. And here is the remnant of the Eustachian tube, this line. And this is the one is crossing the coronary sinus. Those are the landmarks of the triangle. And at the apex is the AV node. So in 90% of hearts, AV nodal artery originates from right coronary artery near the crux of the heart. In the other 10% of hearts, the artery arises from the left circumflex coronary artery. Slowing conduction, the AV node conveys the impulse to the His or AV bundle that is approximately 10 to 20 millimeter in length and 1 to 3 millimeter in diameter. From the apex of Cox triangle, the angle formed by the junction between the tendon of Todaro and the annulus of septal leaflets, that's where the landmark of the AV node is. The His bundle courses anteriorly within the right fibrous trigon. I said earlier from some slide I took that the bundle of His usually pierces through the right fibrous trigon. Right fibrous trigon is that point that is in between the tricuspid valve, aortic valve, and mitral valve is the right fibrous trigon. So this bundle of His is going to press through it to get to the left side. So within the His bundle is an artery arising from either branches of left anterior descending coronary artery or posterior ventricular branches of the right or left circumflex coronary artery. At the crest of the muscular IVS, the His bundle divides into the right and left bundle branches. So this is an image that is showing that. So this asterisk is pointing at the AV node, and this arrow is pointing at the coronary sinus. So this is that apex where the Eustachian tube remnants, the tendon of Todaro, and the septal leaflet of tricuspid valve, where they meet. At that apex is the AV node. So the bundle of His arises from here and pierces through the right trigon that I said, pierces through here and then divides into the RBB and the LBB. So other landmarks are depicted there. This is the anterior leaflet of the mitral valve. And this is the posterior medial papillary muscle. Yeah. So the left bundle branch is spread out in a subendocardial fan-like distribution, posterior inferior to the membranous portion of the IVS. Although subendocardial left bundle fibers are not so discrete anatomically, they function as anterior and posterior fascicles with possibly an intermediate fascicle. So the anterior fascicles fan out towards the apex. They form a plexus and branch at anterolateral papillary muscle. So the Purkinje fibers spread from the subendocardium intramurally to the subepicardium, the way the wave of depolarization spreads from subendocardium to the subepicardium. So from the His bundle, the right bundle branch, so I'm coming back to the right bundle. So it gives us left bundle and continuous right bundle. So the right bundle branch also continues 10 to 20 millimeter as a discrete 1 to 3 millimeter diameter structure, deeply buried in the muscle of IVS. It resurfaces near the papillary muscle of the conus, that is the muscle of Lancissus, superiorly on the septomarginal trabeculum. So then other landmarks, say the right bundle can pass over the moderator band to the right ventricular free wall, or more frequently over one of the trabeculae carni to reach the ventricular wall near the anterior papillary muscle. So when it reaches the free wall, it branches into a finely distributed subendocardial anastomosing plexus. A small branch usually bends sharply backward along the upper IVS to supply the conus. So in some hearts, there are accessory muscle bundles that span the fibrous atrioventricular rings. Remember, the fibrous atrioventricular ring is like a delay point. So we have some muscle bundles that can span over them. That is, it will bypass that delay and connect atria to ventricular muscle directly, and thus bypassing the AV node. They are called bundles of Kent. These muscle bridges offer low resistance pathways for impulse to travel from atrium to ventricle, and they form the anatomic basis for Wolff-Parkinson-White syndrome or accelerated AV conduction. Kent bundles can be situated anywhere along the atrioventricular annuli. So I'm going to coronary circulation now. Main coronary arteries arise from funnel-like openings in the aortic wall at the right coronary leaflet and left coronary leaflet, most often in the midline of the sinuses. There is usually a single ostium for each main coronary artery, left and right. However, there are some variations. Occasionally, there will be a separate small ostium near the right coronary ostium for the conus branch of the right coronary artery. There's supposed to be a conus branch that is usually given by right coronary artery. So a variation can occur in which there will be an additional ostium for it instead of it to be given off by the right coronary artery, and it has a clinical significance. Another common variant is a separate ostium for the left anterior descending and the left circumflex coronary. So instead of it coming as left main coronary artery, the two branches will come from their ostia directly. So you have left circumflex, one for left circumflex, one for left anterior descending. Thus, at coronary arteriography, perceived absence of a left anterior descending or left circumflex coronary artery may be due to selective characterization of one of the two ostia. Arising from the left posterior aortic sinus of Valsalva, the left main coronary artery is a muscular artery that passes anterior and somewhat leftward, posterior to the RVOT and anterior to the left atrium. Left main coronary artery is short, usually less than 1 cm, and bifurcates into left anterior descending and left circumflex coronary arteries. Coronary arteries are enveloped by loose connective tissue and epicardial fat. Left anterior descending lies in the anterior interventricular sulcus, extending down the anterior surface of the heart inferiorly to the apex and frequently turn around the apex to the distal part of the inferior cardiac surface. It has some branches, including a first and often a second diagonal branch that supply the anterior left ventricular free wall, or one or more large septal perforator branches, and a number of septal branches that supply the anterior two-thirds of the muscular IVS. On the cardiac surface, there are small ventricular branches that supply the medial aspect of the right ventricular free wall. Frequently, there is a prominent coronary artery, that is the intermedius coronary artery, that arises from the bifurcation of the left main coronary artery. So in between that point where it bifurcates into left anterior descending and left circumflex, you see the intermedius coronary artery in some people. This artery supplies the anterolateral portion of the left ventricle. So coursing in the left atrioventricular sulcus, the circumflex coronary artery gives us superiorly 1 to 3 anterior branches, 1 lateral and 1 posterior branch to the left atrial wall. The circumflex artery continues in the atrioventricular groove around the left lateral aspect of the heart. Several branches called obtuse marginal arteries supply the anterolateral wall of the left ventricle. Deep to the coronary sinus, the circumflex coronary artery continues posterior inferiorly to the crux of the heart. In about 15% of heart, the circumflex coronary artery crosses the crux of the diaphragmatic surface and turns to the apex to become the posterior descending coronary artery, supplying the inferior wall of the left ventricle and also portion of the inferior right ventricle adjacent to the posterior interventricular sulcus. So this is an image that is showing some of these. So we have here the circumflex branch of the left coronary artery. You can see coming here and it's turning posteriorly. This is the left anterior descending and is giving its diagonal branches here. Then we have the right coronary artery. It is coming. This is the conus branch that supplies the RVOT. Then further down here, you can see a preventricular artery that I think it supplies the RV. Then here we have the right marginal artery, and then it turns posteriorly. So with this coronary artery arrangement, the heart is said to have a left dominant circulation. I'll just quickly flip back. So the dominance depends on which artery gives the posterior descending coronary artery. In about 25% of that, the superior vena cava ostial artery that gives rise to the sinoatrial node artery is a branch of the circumflex coronary artery. But in 70% of hearts, it arises from proximal portion of the right coronary artery. So if it's coming from so in the remaining 5% of the heart, the blood supply to the sinoatrial node has a dual source from both right and left circumflex coronary arteries. So 25%, it may be coming from a branch of circumflex, 70% from right coronary, and you could have dual source supplying the SA node, 5%. The right coronary artery originates from the anterior or right coronary sinus subacava, passes rightward under the right atrial appendage. First branch is conal branch that supplies the RVOT. In about 20% of that, the conal artery arises from a separate orifice in the right coronary sinus. This clinically important vessel is that it can form a collateral circulation where the left anterior descending coronary system is occluded. So another early branch from the right coronary artery is the artery to the superior vena cava orifice that gives the sinoatrial nodal artery. The right coronary artery gives branches superiorly to the right atrial wall and 1 to 3 branches inferiorly to the free wall of the right ventricle. It also gives an acute marginal artery at the point where it's turning, when it gets to the margin, gives this marginal artery before it turns to the posterior side. So it continues inferiorly in the right atrioventricular sulcus, passing under the inferior vena cava at its connection with the right atrium. It continues posteriorly to the crux of the heart and makes an anterior loop into the posterior atrial septum. In 90% of that, the AV nodal artery is given off by the right coronary artery. It passes in the inferior interatrial septum superiorly to supply the AV node. After giving off AV nodal artery, it turns towards the apex to course through the posterior interventricular sulcus as the posterior descending coronary artery that supplies the posterior inferior surface of the left ventricle, parts of the posterior right ventricle adjacent to the posterior interventricular sulcus, and by small septal perforators, the posterior 1/3 of the interventricular septum. So I said the anterior 2/3 supplied by left anterior descending, then posterior 1/3 by the posterior descending artery. So when the posterior descending coronary artery is a continuation of the right coronary artery, as occurs in 75% of us, the heart is said to have a right dominant circulation. In some hearts, the posterior descending coronary artery wraps around the apex and supplies the distal portion of the anterior left ventricular wall. So the terminal distribution of the left circumflex and the right coronary arteries posteriorly are reciprocally related. So it could be coming from the left circumflex. So the left circumflex could be the one that is giving the posterior descending. Then it's a dominance that is left dominance in that situation. But if it is coming from the continuation of the right coronary artery, it is right dominance. So then in 5% of us, the right coronary artery is a congenitally small vessel supplying only branches to the right ventricle, with the entire left ventricle supplied by the left coronary artery. So I'll just talk about the venous drainage. The cardiac veins, they generally follow the epicardial distribution of the coronary artery. So you see the veins following the arteries. They lie embedded in epicardial fat and are usually superficial to the coronary arteries. That is, they lie on the coronary arteries. They receive blood from the myocardial capillaries and carry it back to the right atrium. Most of the venous return to the right atrium is via the coronary sinus, the biggest vein. The great cardiac vein accompanies the anterior. So I'll be mentioning the veins that accompany different arteries now. Great cardiac vein usually accompanies the anterior descending coronary artery. Small cardiac vein comes with the right coronary artery as it's turning at the margin from anterior to posterior, while middle cardiac vein is usually accompanying the posterior descending. I'll still depict it in an image. So the middle cardiac vein is usually following the posterior descending coronary artery. So yes, so I'll go on. So the great cardiac vein drains towards the base of the heart and then follows the left circumflex coronary artery posteriorly in the left atrioventricular sulcus, joining the coronary sinus just beneath the left inferior pulmonary vein. Okay, so the great cardiac vein has valves at its connection with the coronary sinus. So it receives veins from other other, so from anterior muscular IVS, anterior and lateral walls of the right and left, so that's the places that drain into it, and the left atrium. So it courses on the diaphragmatic surface of the left ventricle, and the posterior cardiac vein of the left ventricle accompanies the circumflex coronary artery to connect to the coronary sinus. So together with the posterior cardiac vein, they drain into the coronary sinus. So the middle cardiac vein lies in the posterior interventricular sulcus, overlying the posterior descending coronary artery, like I earlier mentioned. So he also received tributaries from posterior muscular IVS, posterior ventricular walls, and empties into the coronary sinus, close to the coronary sinus ostium. While the small cardiac vein accompanies the acute marginal artery, branch of right coronary artery, and drains the anterolateral wall of the right ventricle. So it follows the course of the right coronary artery in right atrioventricular sulcus and receives tributaries from right atrium, empties into the coronary sinus near its ostium and the right atrium. So on the anterior aspect of the right ventricle, there are 3 to 12 anterior cardiac veins that empty directly into the ventricular, through the ventricular wall into the conal region, into the small cardiac vein, or directly into the right atrium through separate orifices. So now I'll talk about coronary sinus. It's the continuation of great cardiac vein. It's 3 to 5 millimeter in diameter and 2 to 5 centimeter in length. It courses in the left AV sulcus inferiorly, receiving veins from left atrial and ventricular walls. A small vein draining from the roof of posterior left atrium between the left and right pulmonary veins, called oblique vein of the left atrium or vein of Marshall, is the remnant of embryologic left common cardinal vein. So when this cardinal vein persists, is known as persistent left superior vena cava and connects left innominate vein with the coronary sinus. It's said to be clinically important in that when a catheter is passed through the left median basilic vein, it enters the right atrium through coronary sinus and are difficult to maneuver into the RV and out the pulmonary artery. So this is an image showing the venous drainage, how they accompany the different arteries. So here we see the great cardiac vein that is coming with the left circumflex here. And here we see the middle cardiac vein that is accompanying the posterior descending. Here we have the small cardiac vein accompanying the right coronary artery, and this is the coronary sinus. So it's a continuation of the great cardiac vein, and we have these veins that are draining into it. See the posterior vein of the left ventricle, the middle cardiac vein, everybody eventually joins, and see the small cardiac vein all emptying into the coronary sinus, and all the other landmarks are as depicted. So I will talk about lymphatics. So in the subendocardial connective tissue of all 4 cardiac chambers, there is a plexus of valved lymphatic vessels. These channels drain through a web of anastomosing lymphatic vessels that envelope the myocardial fibers. They course through the interstitial connective tissue, draining towards the epicardium, where they form an epicardial lymphatic plexus. These vessels join on the epicardium to form several large lymphatic vessels that follow the course of the epicardial coronary arteries and veins. The major lymphatic trunks, they drain into AV, atrioventricular sulcus, and form a single large trunk that passes over the top of the left main coronary artery and under the arch of the main pulmonary artery. This trunk courses to the left of the aortic root, where it exits the pericardial sac to join the left mediastinal lymphatic plexus, draining into the mediastinal lymph nodes, and finally into the thoracic duct. Thank you for listening. This is my reference. Thank you.
Hello.
Yes.
Thank you very much, Dr. Kidara. I presume you are done. I stepped out a bit briefly.
Yes, I'm done.
Thank you very much. At this point, we ask colleagues on the call to ask questions, contributions, clarifications. Kindly unmute, then ask your question, please. Okay, fellows, consultants on the call, any contributions whilst we wait for colleagues to ask questions? Okay, Dr. Abdul Aziz, kindly go ahead.
Okay, thank you, Dr. Kidara. It's just to add to what you said in terms of the interatrial fibers. I think we have three. We have the Batchman, we have the Torel, and we also have the working batch. I think this just has to be added to it. But I'm not
Thank you.
I can't really now recollect which one is the anterior, the intermediate, and the posterior, because they are being arranged in the way that they are arranged. That one is at the anterior level, one is in between, and the other one is posterior. Thank you.
Yeah, thank you, Dr. Abdulaziz. I will
Hello,
include
Doc.
it.
If you follow the order, the BTW, anterior, middle, and posterior, it's just BTW, just anterior, middle, that order. Batchman, the Torah is the middle, then the posterior is the W.
Okay, thank you, Chief.
Okay, let's appreciate the presenter, Dr. Kidara, for the wonderful presentation. So in the absence of further questions, we'll continue with the MCQs. So let's kindly prepare. If you are in line, we ask as many people to prepare